for having me, Celine. That was a beautiful introduction. We're going to start out today talking about a syndemic, which you can see here on the slide. Importantly, a syndemic is an aggregation of two or more epidemics. We have the addiction epidemic, the COVID pandemic, and racism, which has been an epidemic ongoing, but right now is in an acute state as a result of recent events. And so what we need to know from the faith community is that distress is high, people are struggling. Are people who are in the most marginalized populations, who are the most vulnerable with the least access to resources, are the people who will struggle the most. And for certain people with substance use disorders, especially Black and brown people with substance use disorders, Black and brown people with substance use disorders in lower socioeconomic communities, Black and brown people with substance use disorders in lower socioeconomic communities without access to faith communities who are supporting their families and their communities are going to be at the highest risk. Does this statistic shock anyone? Drop it in the chat box. Just be like, nope, I'm not shocked, or be like, that is shocking. 80% of people, John said, I use disorder, do not receive treatment. This is a tragedy. I challenge you, besides other substance use disorders, to find another medical illness where we accept that 80% of people do not get care. As I was saying on the previous slide, the reason I call it the addiction epidemic and not the opioid epidemic is because if you look at the prevalence, so how common substance use disorders are, this is in the United States, this is a slice, this is 2019 data. So over the year of 2019, 20 million adults met criteria for substance use disorder. I know, Bridget, I thought we were bridging the gap better than that also. Crazy, we're not. This is a current statistic. So 20 million people with substance use disorder, only 0.6 million of that, add the prescription pain. So 1.8 plus 0.6, only 2.4 million out of those 20 million have opioid use disorder, opioid being prescription pain pills and heroin or other opioids. The remainder 18 million, so 90% of people with substance use disorder have a substance use disorder that's not the opioid epidemic. And what I want to drive home is, yes, the opioid epidemic is killing people right in front of our eyes, but so are these other substances. It's just taking longer. And so we have to put our eye not just on the opioid epidemic, but on the substance use disorder epidemic as a whole that we have in this country. On top of that opioid epidemic, so I'm going through the pieces of the syndemic right now. So we already have 20 million people with substance use disorder. 2.4 million of those have opioid use disorder. 80% of those are not going to get any treatment. So that's like 1.6 million, if you let me do lazy math. 1.5 million people with opioid use disorder not getting treatment. And then here comes COVID. And since COVID started, more than 35 states have reported increases in opioid-related mortality, whether that's an opioid overdose or dying for some other reason with an opioid involved. This is staggering. We were making progress. So Dolores, this is part of the problem. She says, is that 80% broken down by race? And we're going to get into this. So much of our data is not measured by race. It's a problem. So no, I cannot find that breakdown by race. But what we do know is that Black individuals with substance use disorder are 35 times less likely to be prescribed buprenorphine, which is part of the gold standard for the treatment, 5 times less likely. So while we don't have that 80% broken down by race, we can rest good and assured that the majority of those 80% are going to be disproportionately represented by Black people. So COVID is showing us more than 35 states have reported an increase in opioid-related mortality. This number was going down until year over year for the last couple of years until COVID came. And so the amount of distress is high. The uncertainty and the fear is high. Both of those drive substance use disorders to relapse, but also coping skills have been ripped. So a huge part of keeping any illness in remission, substance use disorders included, is connection and support system and predictability. And all of those have been stolen by COVID. And so this is a very, very dangerous time for people with substance use disorders. From COVID, so disparities. Black people are dying at 2.5 times the rate of white people from COVID. And what COVID has really done for us, we already knew there were health disparities. We already knew there was social injustice. We already knew there was inequality to access and quality of care. COVID has shone a light on that. So our very, very most vulnerable people are taking the short end and the long end of the COVID stick. And so when we look at the root causes of the disparities that we see in substance use disorder, we really can put them into these 3 buckets. And we do have race-based data, although just the surface of it, and that's one of my biggest platforms, is trying to require race-based data collection around every single illness, including substance use disorders. We do better in physical illnesses, but we still have improvement there also. But if we can look at the need as it relates to substance use disorders, look at the access and look at the retention, these 3 buckets really give us the root causes for the differences in health outcomes that we see with addiction between white people and non-white people. And so we look at the need, the largest absolute percentage increases in the opioid overdose deaths are among Blacks. We've had 103% increase in overdose deaths. Thinking about the face that you've seen of the opioid epidemic, is this the face that you've seen? Black faces? This is not the face that you've seen. The face that the media is showing us of the opioid epidemic is the young white suburban face. And they are most certainly had dramatic increases in overdose deaths and opioid use disorders. But the problem with that is that when Black folks don't see ourselves in the coverage, we think it's not affecting us. When in reality, we're more than doubling the overdose deaths and more than 3.6 timing the overdoses from opioids. So part of what we need the faith community to do is to be proactively outreaching and being part of the education that says, this is affecting your community also, because that's not the face that we're seeing. And so as we're taking care of all the communities, and I see that we have a mixed group here, as we're taking care of all of the communities, we have to be very proactively about taking care of those who are most vulnerable that the messages don't always get to. This is part of that group. When we look at access, so no, I wouldn't say that this is Trump syndrome. This is America. So in America, the default face is the white race. You know that because everybody else is defined as a minority, right? And so the default is white. The default for our media has been white. The default for our systems have been white. The default for our infrastructure have been white. And so that is more an American phenomenon, an American legacy, than that is a Trump legacy. Medicine is not protected from that legacy. So even when we look at the way we handle race in medicine, like I said, a lot of things we're not even measuring by race. You look at our research studies, the research is done in white populations. And so it's just pervasive. It's just pervasive. So Catherine says, I have more referrals, people seeking services from white candidates than I do Black candidates. So that's interesting that you say that. It depends on geography, obviously, right? But look at this access. Black folks are actually twice as likely to seek treatment, but less as likely to receive ancillary support services for their needs while they're in treatment. And like I already mentioned earlier, 35 times less likely to receive buprenorphine-related visit, which is part of the gold standard for MAT. And so there are so many barriers that keep Black folks from accessing treatment, which might be why, depending on what your geography is, seeing more white folks come in. Part of the barriers are, and we'll talk through this later, biological, psychological, social, cultural, political. Part of the barrier is the stigma around getting help for substance use disorder. So even being able to tell somebody that you need help, even though that stigma seems to be lower in Black communities as we're seeking treatment more often than other races. But part of that is the stigma. Part of that is the distribution of where treatment services are. And so especially when you look at the overlap between lower socioeconomic communities and communities of color, then if it's difficult to get to treatment, if I have to take off work and I'm paid hourly to go to treatment, if I have nobody to take care of my kids, if I'm the primary breadwinner in my family, there are so many barriers that prevent accessing treatment. Cheryl said, what did the statistics look like during the Obama years? These are longitudinal statistics. So I hate to tell you, I know everybody is trying to blame this on Trump. This is a legacy. This is a broken system that has been broken at least for the 20 years that I've been practicing medicine. And then retention. Black people are more up to 5 times, sorry, that should say more likely, up to 5 times more likely to drop out of treatment. And so what we know is that higher need with decreased access and decreased retention in treatment leads to the disparities that we're seeing. And so we look at the root causes. They're historical, like I've been talking through. They're systemic, and that's through every system, not just healthcare. Education disparities lend to substance use disorders. Housing disparities lead to substance use disorders. Financial disparities lead to substance use disorders. Criminal justice disparities lead to substance use disorders. And these are very, very pronounced between the Black race and other races. But there are also other characteristics that we marginalize people by. So socioeconomic status, rural geography, older age, LGBTQIA plus identification, all of these are associated with the same types of disparities that I just went through for Black people specifically. And it's because of the social, cultural, political environment that marginalize and disconnects these folks from the support systems that they need. And so what I'm asking from the faith community is that we are the ones that try to help in bridging and making those connections and bringing people back into the pack. So I always say we are pack animals, humans. And when it slinks off and that animal dies, and substance use disorders are a manifestation of that. Dr. Wisdom Plow blessed me more than once on that panel. So she taught me the word syndemic. She also used this quote: "This country treats Black men and boys as a problem to be solved rather than a wonder to behold." That was so powerful to me. And it's true. And we can replace Black men with poor people. And we can replace poor people with members of the LGBTQ community. And we can replace members of the LGBTQ community with people who are of a religion that is different than my own, or atheists. And so humans, we are so intent on marginalizing and keeping people out of the pack and treating them as a problem to be solved instead of as a wonder to behold, that what I would love is for us to start thinking through every single individual we see, every single family we touch, every single community we join. This is a precious wonder to behold, because we treat things that are precious to us with care, and we go above and beyond, and we protect them at all costs. And where there are too many marginalized and vulnerable communities that we are not treating with that level of wonder. I already went through this. Every single one of these, I could go through and put a graph up to you and show you the disparities in every one of these systems. And all of these systemic disparities are driving the addiction crisis that we see here. And so I have everyone I know is drinking more, smoking more pot, eating more, watching more TV, and generally accomplishing less. That's the COVID effect. And so we're going to go through and we're going to talk about biological, psychological, social, cultural, and political effects. Biologically, when you're stressed, your stress hormone axis increases. Cortisol is the main hormone that's there. But what that does is prepare you for hibernation, right? And what do animals do when they hibernate? First, they pack in the food, they stock up their calories. 2, they climb into a dark, safe space. 3, they go to sleep and they lay around and they do nothing to conserve their energy until the time at which the environment is safer. This is what you see happening to all of us. And so our healthy behaviors and routines got snatched from us at the same time our stressors got pushed through the window. And so as your brain is looking for a dopamine signal and things to survive, it's going back to those very basic determinants of a dopamine signal that tell you all see ourselves reverting back to that very instinctual survival behaviors that our brain interprets as keeping us alive. Yes, alcohol sales up 55% since COVID. Marijuana use up. Generalized anxiety disorder up. Suicide attempts up. Overdose deaths from opioids up. COVID is wreaking havoc on our communities. I know, right, Dr. McCain? That quote by Dr. Wisdom, boy, it's the truth. So when we look at current psychosocial political factors, because I just because of sake of time didn't take us through the whole history, but we know there's a whole history that this is sitting on top of. When we look at the current psychosocial, cultural, political factors that are driving this risk of substance use disorders that we're seeing in current day segregation. Does this surprise anybody to see me language it this way? We are almost as segregated now as a country as we were in the 60s. So you look at this study over on the right, and it says, assuming the average white and Black American each have 100 friends, this is what the racial breakdown of their friend networks looks like. White people, 91% of their friends are white. The average white American has 1 Black friend, 1 Latino friend, 1 Asian friend, 1 mixed race friend, 1 friend of another race, and 3 that they don't know about. That's segregation. You look the same, the average Black American has 83 Black friends, 8 white friends, 2 Latino, no Asians, 3 mixed race, 1 mixed race, 4 friends of unknown race. The problem with being segregated is that it doesn't give us the opportunity to learn and have positive interactions with people that don't look like us. And that drives stigma and that drives marginalization. And stigma and marginalization drive distress, drive substance use disorders. Micro and macro aggressions. So microaggression doesn't necessarily have bad intent. And sometimes you wonder, did that actually happen, or am I thinking that's just me? But microaggressions all day, every day actually lead to a medical term called weathering, which increases that stress cortisol axis, leads directly to diabetes, heart disease, high blood pressure, heart attacks, strokes, depression, anxiety, substance use disorders, and the shortened lifespan that we see for Black men in particular in this country. Implicit bias and explicit bias. So we're going to spend a little bit of time on stigma, and then we're going to roll into implicit bias, because this is where I think we can really make a big difference quickly. Stigma, the basic human need is to belong, to be accepted for who I am without conditions, and for my autonomy and my decision, my ability to make decisions for myself to be respected. That is the basic human need, underlies everything. I should say the basic psychological needs. The basic human needs are like regular food, safe place to live, nurturing, food, water, sex, and nurturing are the basic needs. These are the basic psychological human needs. And so when we look at people that have substance use disorders, understood? Nope. Accepted? Nope. Respected? Nope. And so think about when you've been your most vulnerable from an illness. Did it help you to have somebody tell you, just get over it? No, that pushed you on an island. Did it help you to have somebody say you got yourself in this situation? Even if you did, even if you jumped off a cliff on purpose because you were cliff jumping and then you broke both of your legs, nobody, while you were laying there with both of your legs broken, nobody said to you, that's what you get. But that's how we treat people with substance use disorders. Did it help you when you were in the hospital? And you may have had this experience because sadly people get treated terribly in our healthcare system, but where you felt totally disrespected when you were at your most vulnerable, that did not help you. And so what we have to do, and I'm making this plea to the faith-based community, is to be the loudest advocates, proactively out there shouting with your megaphone to people with substance use disorders. We see your human value. I understand you. I accept you. I see you as a human separately from your illness, which is addiction. I respect your autonomy to make decisions, and I want to support you in that. If we could just start sending that message on a large scale and start undermining the stigma for that we have against people with substance use disorders, that would reduce some of the barrier of getting people connected for treatment. That would reduce some of the barrier of keeping people in treatment long enough to get that illness in remission. That would also reduce some of the barrier and those disparities around how we see us delivering support for this illness. And so when we look at what do these statistics look like for the Latino community, so the Latino community actually splits. The white Latino community has statistics that look as much disparity as Blacks, but not performing close to whites. And that's because people treat you based on what they see. So when we look at negative evaluation of one group and its members relative to another group, that's the definition of bias. I think I know something about you just because I think I know something about a group that you are part of. So you see me and I'm a Black woman and you think you know something about me. Or you see me and I'm non-gender conforming and you think you know something about me. Explicit bias is conscious. I have that bias because I believe it to be correct. I consciously act on that bias. It takes time. I am motivated to reinforce that bias for me. This has decreased in healthcare. It has also decreased just across America in general, but it is still very much a thing. Implicit bias is pervasive. It has not decreased. It is difficult to measure. It is persistent. It is pervasive and invasive. And it is unconscious and it is unintentional. Yes, language matters. And so every single one of us has implicit bias, point blank, period. It is the way the brain works. And so we're going to go through a little bit of an exercise because I think if each and every one of us just starts with ourselves and starts recognizing our implicit bias that we hold against other people of other groups, people with substance use disorders included, then we can start breaking down that stigma and we can start being the megaphone that wraps our communities, faith community, educational communities, finance communities, healthcare communities around these people who desperately need to be brought back into the pack. I want to do an emphasis. Dolores, thank you for pointing that in. She said it would go a long way if we could just get folks to use the term substance use disorder rather than folks who abuse drugs. I agree with that because abuse holds connotations. It's an accusation, right? That's not pointing to that you have an illness, because you could say people with diabetes abuse blood sugar. That don't even sound right, because it is the stigma that wraps around substance use disorder. So for any illness and really for any characteristic, you will always hear me lead with the person. So people with substance use disorder, people with diabetes, people with schizophrenia, people who use drugs. If you lead with the person, language does matter. That starts to train you also to start thinking of the person first. So you will never hear me say an addict. That is a person with an addiction, and they are so much more than that illness. So let's talk about implicit bias a little bit. I'm going through, because we have this data in healthcare, This data is not as cleanly available as it relates to the faith-based community interacting with individuals and communities, but it applies. So when we look at how health is affected by implicit bias, so remember, implicit bias is not conscious. It is not intentional. It is not overt. It is operating under the surface and we don't even know it's there, but it's affecting the way that we interact with people. And so what we know, physicians, these are, you can see the study down there from the American Journal of Public Health. Physicians that have high implicit bias, this is implicit racial bias study. Physicians that have high implicit racial bias, Black people experience longer wait times. So their Black patients had longer wait times than their white patients. They spent more time with their white patients, not intentionally, probably just because it felt more comfortable. They showed preferential treatment to white patients, so they would fill their prescriptions faster. They would go above and beyond more often. They would give them appointments in between appointments. All of this was borne out by data. None of those physicians was trying to mistreat their Black patients. This was purely a result of implicit bias that they didn't even know was functioning over the surface. The important concept here is that intent doesn't matter. Impact matters. The quality of care for physicians with high implicit racial bias, the tone that they talk to their Black patients is different. And remember that previous slide, understood, accepted, respected, right? The tone changed. They sat further away from their Black patients than their white patients. They collaborated less. So their discussion about how we're going to move forward with your care plan was less collaborative and more authoritarian. That led directly to what this study found about how much the patients followed the recommendations from physicians with high implicit racial balance. They were less likely to fill prescriptions. They were less likely to follow through on recommendations. And of course, that leads directly to poor outcomes. And so while this is data specifically about physicians with high implicit bias, we, every single one of us, are prey to this exact same dynamic. So as a member of the faith community, if you have a certain faith and you don't have a faith who are of a different faith, even though you're not explicitly trying to sit further from them, trying to talk to them with a different tone, being less collaborative or less compassionate, your implicit bias will drive that. And so each and every one of us has to do the deep and difficult work to look at what biases we've developed over our lifetimes, because bias develops organically as much as it develops intentionally. It's just a feature of your experiences. And the brain experiences things that we've been through before that we can predict as safe. This includes people. So if you become the minority for whatever reason along whatever dimension you define yourself, so a woman in a room full of men, you will feel safe than a woman in a room full of women. A transgender woman in a room full of transgender people will feel safer than in a room full of non-transgender women. A short person will feel safer in a room full of short people than in a room full of tall people. It is just the way the brain works. And so we all have to hold ourselves to looking at our own implicit bias. So a little bit of neurobiology, because I never gave a talk without showing a picture of the brain. When you look at the brain, I'm going to divide it for simplicity into two parts. The deep brain, so if you connect these two lines that I'm drawing with this finger going down and this finger going through my temple, right in the middle of our skulls is our deep brain. That's what we share with animals. That's where our limbic system is, and that's where our dopamine system is. Our limbic system houses our emotions, our fight or flight syndrome, and our survival instincts. That ends, if you look at the covering of the brain, which is what you see here in this picture, the frontal, the cortex, the very, very front part underneath your forehead, right over your eyes, is your prefrontal cortex. This is the biggest in humans. And this is where thinking and planning and executive skills and strategizing and impulse control and decision making. All of that is in the cortex. What's very important is that our deep brain, so this amygdala, which is responsible for fear and anxiety, that fight or flight syndrome, our hippocampus, which is responsible for factual memory, and amygdala actually lays emotion on top of factual memory. So when you look at a person you haven't seen in a long time, your hippocampus says, oh, eyes right there, nose right there, mouth right there, skin that tone, hair looks like that. That's Judy. Your amygdala remembers the experiences you have with Judy, and you either go, Judy, or you go, Judy. That's automatic. That's not to mean we don't have control over it, but in your limbic system, when that signal generates or that emotion comes, there's a good half a second before it gets to your prefrontal cortex where you have conscious control over what to do with that information. So what I always tell people is we can't expect ourselves not to have implicit bias. We're gonna have it. It's the way the brain works. We cannot expect ourselves not to have an emotional response as a result of that bias. That is out of your control. Your emotional responses develop in response to whatever is going on. What is in control is when it finally lands on the prefrontal cortex and we take note of it and we increase our awareness of it, and then we decide what to do about it. Our limbic system can operate without any prefrontal cortex involvement. And that's what you see with those doctors when they're unintentionally sitting further away from a patient who doesn't look like them. And so implicit bias affects our attitudes. It is our attitudes and our stereotypes that affect how we understand other people, other groups of people, how we act towards those people, the decisions we make that affect those people, and it's all under the surface. So we're going to do an exercise right now, and I want everybody, this is a judgment-free zone, period. Completely judgment-free. I want you to have your reaction. I want you to take note of what your reaction is. I'm going to put pictures up. And I want you to type it in the box. No judgment zone. Just once that emotion lands on the prefrontal cortex, that first reaction, I want you to type it in the box. No, because we're about to put some ugly stuff in the box. This is important work. So no judgment zone. I don't want anybody to comment on anything they see in the box. We are just creating a safe space for us to own our reactions so that we can then make a different choice about how to respond. Here's the first one. What's your reaction? Type her in. Healthy, yum. Oh, Monica don't like apples. Healthy, positive, teacher. Ugh. Oh, Catherine don't like apples either. Delicious, healthy, delicious, juicy. Dave said too many carbs. He's trying to get his COVID-15 off. Pleasant, yum, teacher, fruit, very pretty apple, sweet, pretty, juicy. Have any of you tasted this apple? And yet you have all of these conceptions just by looking at it. How about this? Type them in. Rotten, gross, ugh. Oh, Dolores said, you won't trick me twice. Yuck, nasty, bad, rotten, ugly. Oh, cider from the apple orchard. That's based on your childhood memories, I bet. Too ripe, mellow, unsure. All of this is based on experiences that you've previously had with apples that look like that. You don't know this. This might be the most amazing apple on the planet Earth. That red apple might be rotten on the inside, but your experiences tell you that when apples look like the red apple, they're delicious. And when apples look like that other apple, they're not. Now, this is an American crowd. When I was first developing this exercise, I actually tried it out on one of my kids' friend's dad, who for all I knew was a white guy. So I told him I'm doing this talk on implicit bias. The kids were in band practice. And I was like, let me try this out on you. And I showed him the 2 apples, and he developed his positive response to the second apple. And he said he grew up in Chile, and they picked apples that looked just like that off of the tree, and they were delicious. And that brought back fond childhood memories for him. And he remembered when he first immigrated to America. Now, mind you, I thought this guy was white. I had no idea. So I'm operating in my own implicit biases about him being a white guy. He was born and raised in Central America, immigrated to the US. He saw those red apples in the grocery store and was like, what is wrong with those apples? It is all about our experiences. Our brains does define what things mean based on what we've seen. And so when you look at the images of people with substance use disorder that we see on TV, and you look at the images of Black people that we see on TV, and you look at the images of people who are poor that we see on TV, you can understand why we have the implicit biases we have. So we don't judge ourselves for having these biases. This is the way the brain works. We judge ourselves for refusing to take note of those biases so that we cannot act out on them. So just like you guys were super open, thank you. I love it. All right, give me your reactions. Type them in the box. Honest, unfiltered. Own it. Junkie, hurting, sad, junkie, substance user, in pain, pained, need help, sorrow, hurting, addicted to drugs, needs a safe place. Propaganda, that's interesting. Confused, why? IV user. Right? So thank you, because we usually don't allow ourselves the same latitude to really look at the reactions we're having when it comes to people, but we have to. So if your reaction to this picture was anything other than, how can I help? I want you to deeply examine that reaction and the implicit bias and move yourself to a position of, how can I help? Also, I want you to think about, when you see this picture, the singular identity that showed up here is drug use, suffering, pain, needs help, right? I also want us to see the human being in this picture. So I don't want it to just that we see a picture of suffering, which is going to be our initial reaction, or that we see an addict or we see a junkie and all of the marginalization and stigmatization that are in those words. We can have that as the first reaction. But once it lands on the prefrontal cortex, the first step is thinking brain says, that's a person. And the second step is thinking brain says, how can I get over my bias so that I can position myself to understand, accept, and respect the person in front of me? Okay? How about this? First reaction, type them in. No, alone, raw, mother, sad, someone's mother, desperate, hot, isolated, lonely. Stop it now. Broken, stuck, trauma, broken, in pain. Again, why? What happened? James, hurting, hooked, painful, trapped. A lady using her coping skill. So you see the quality of these answers are different, but did you also notice the time that it took these answers to start coming in was longer? That's because you're in tune. That's because you're in tune. And so that's because I'm waiting for this first reaction to hit my prefrontal cortex, and then I have to examine that. And so some examination is happening before we even get to these answers. And you can already see the quality of the change just in the 7 minutes that we've been doing this exercise. How about this one? Honest. Put them in quick. Taking too long, you think about it. Put it in quick. Bad. Harm the baby, kill the baby, scared, stop, selfish. Irresponsible, pregnant, feel sorry for the baby, pregnant, yikes, alcohol syndrome, helpless. Really? Cut it out. Unhealthy, stop, immature, don't care about herself. Oh no, pregnant, need and reduce, pregnant. So you see how even though we made some progress from that first picture to that second picture, we lost that progress when we saw a pregnant woman. Pregnant women with substance use disorder are among the most stigmatized, most judged, most marginalized. It is very hard for people to find compassion for the mother because they feel like the compassion for the fetus competes with the compassion for the mother. But I'll tell you, besides the barriers we enact to pregnant women getting access to treatment, when a woman is pregnant, that is one of the times in life where the drive to enter treatment and to get a substance use disorder into remission is the highest. But the stigma and the risk of pregnant women reaching out for help is so high that even though their drive to stop using is at its highest, the fear of reaching out for help is often higher and prevents them from getting into treatment. So when you have that reaction to seeing this woman, I want you to go through the same exercise. I have received that information from the limbic system. I accept that that is based on the previous experiences I have had. Number one, this is a human. Number two, how can I help her? If we can do that work, for it is so unconscious, it is automatic, but every single time you look at a human being, your brain pulls forward all the experiences from others that they're attaching to that person. And so you literally have to do this, especially when you're meeting somebody new, every single time. This is a human. How can I help? Because if you don't go through that exercise, you will act out on your implicit bias unconsciously without even knowing, even when you have good intentions. But remember, your intentions don't matter. Your impact matters. And so I hope, okay, tell me if this exercise made a difference for you. Is it useful? Is it a skill you can use? Do you think it's going to help you make a difference? Do you think it's going to help you be more effective as a member of the faith community, reaching out to diverse and various communities? Just say thumbs up or thumbs down. Or neutral. Up, helpful, definitely. Good. I do this work every single day on myself. I challenge you. You'll start noticing, you'll be like, oh, do not judge yourself for your reactions. Your reaction is just that, it's a reaction. Your action, that's what you can judge yourself for, because there's a space between reaction and action. So one of the ways you can measure your implicit bias, right, and increase your awareness, this beautiful project done out of Harvard, which is called Project Implicit, and it's this test, the implicit association test. And what it does is measure implicit attitudes against members of different groups. It makes you make a series of judgments, snap, fast, without you being able to think about it. So it basically takes the prefrontal cortex out of it and just has the limbic system doing all the work. and then it does a statistical analysis and gives you an evaluation of that analysis. You can go to projectimplicit.net. I hope that every single one of you will go to projectimplicit.net and send all of your people to projectimplicit.net. This is a list of the IATs that they have, and there's not one for substance use disorder. I wish they would create one. But there's age IAT, religion. That is too small. I can't read what that says. Arab, Muslim, Native, against people with disability, based on race, based on sexuality, based on weight, based on skin tone. Ooh, okay. I did the gender career IAT, and it's basically measuring your bias against women who work. Mind you, look at me. Co-founder, chief medical officer, healthcare executive, consultant. I mean, like, woman that works, that is the very definition of Nzinga Harrison. I have 2 kids. My sons are 14, 13. Do you know I had a gender bias against women who work outside the house? Come on. And that gender bias against women who work outside the house was feeding my own guilt of working motherhood. And once I did that Project Implicit test, then I was like, this explains so much. And I start being able to catch those reactions when they landed on my prefrontal cortex and choose a different action. So I'm telling you, this is eye-opening. You will love it. Do as many of them as you possibly can. Here's an example. So these are my son's thumbs. I made every single person in my family take the race-based IAT. This will show you how it works. So you see on the left, you have the word bad or white people. And on the right, you have the word good or black people. And if you take this on your iPad, like you do it on a touch screen, that's the easiest way. And so the directions here are look at the picture and then touch the square that corresponds. So that is a picture of a white person. So you should touch the square on the left, which says white people. But if you make the accident and touch the square on the right, which says good, that tells this test that you have an association between good and white people. That makes sense? Nod your heads. I can see you on camera. Perfect. Anybody shaking their head? No? Okay. So here is my son. This is a video actually taking the IAT. Oh man, that was supposed to be a video. It didn't come through. I was going to show you him actually taking the IAT, and I actually,
This is on the Southern Poverty Law Center's webpage.
Oh, it is? Yeah, the Harvard Implicit. So I actually, you see it? Pain, bad, black, attractive, hatred, bad, friend, good, black, good, yucky, bad, white people, delightful, good, black person, excitement, good, white people, black people. You saw the hesitation there? The red X is when you push the wrong box. So it makes you do that. That's part 4 of 7. It makes you do that 7 times, and then it collects the data, and then it gives you your results. And so when I had everybody in my family do the race-based IAT, these were our results. Sorry, don't give anybody a seizure. My niece, 4 years old, she can't read, so her test was invalid. She can read now. She's 7. Zaire, my son, he's 14. He'll be 15 next week. He's 11. So this was 4 years ago. He had a mild automatic preference for the white race. That shocked all of us. We are a militant family. His life experiences gave him a mild automatic preference for the white race. My niece Katana, Zena's sister, had no automatic preference. She was 6. My sister Akosawa, we grew up in the same house, raised by the same parents. She had a mild automatic preference for black race. My son Nasir, barely a year younger than his little brother, growing up in the same family with the same parents, He had a moderate automatic preference for Black race. 2 sons, same kid, same family, different experiences. So you cannot know what your biases are unless you measure your biases and unless you start putting your brain around your biases. My mom, 68, moderate automatic preference for Black race. Me, strong automatic preference for Black race. So you know what that means? Because I take care of people of all races, ethnicities, genders, religions, period, you name it. I take care of humans. I know when a 21-year-old Black kid walks in my office, my ovaries quiver. That looks like at work, all no length too far for me to go for this kid. I don't get that same automatic reaction when a 21-year-old white kid walks in my office. Because I know I don't get that same reaction, I have to make the conscious effort to make sure that I approach that 21-year-old white kid the same way, same level of compassion, same level of above and beyond, same level of acceptance, understanding, and respect as I would for that Black kid. That's how you make your biases not shoot you in the foot and not shoot the people that you're interacting with in the foot. Another quote I love, Monique Tula, harm reduction is the practice of unconditional love for people who use drugs. That's beautiful. We suck at it. We suck at it. And we suck at it because of our implicit and explicit bias. So I'm going to just make the assumption that nobody on this call is mistreating people as a result of explicit bias. But I know that we're mistreating people as a result of implicit bias because we don't even know it's there. And so we want to get to treating people who use drugs with unconditional love. We have to examine our biases against people who use drugs. And so here, how do we do that? I'm going to use this trauma framework, and racism is one of the epidemics in that 3-part syndemic that I put there. A chronic, cumulative, ongoing trauma in the lives of Black people in the US is racism. Marginalization, stigmatization, oppression, devaluation is a chronic, cumulative, ongoing trauma for people who are poor, people with substance use disorders, people in the LGBTQIA+ community, people who are otherwise disconnected. And so when we have acute on chronic events like we're having right now with Breonna Taylor, Ahmaud Arbery, George Floyd, Rayshard Brooks, they overlie chronic ongoing trauma for all of groups who have been traumatized, Black people especially. And so we want to move forward when we're approaching people with substance use disorders in a trauma-informed way. Because to be in any of those communities is to have an experience with trauma. To have substance use disorder is to have an experience with trauma and marginalization and oppression. And so we have to realize how widely spread this impact is. We have to recognize what it looks like, what people in pain from trauma look like. We have to respond to it compassionately, understanding, and respect. And we have to resist the risk of re-traumatizing people. So when a person comes and reaches out for help and a door gets slammed in their face, whatever way, that's re-traumatization. And so we have to actively resist that. And the faith community is in a beautiful position to wrap these unconditional loving arms around people who are in need and who are desperate and who are vulnerable and who need us. And so we know that trauma at an early age predicts substance use disorder. And we know that substance use disorder increases the risk of people being victimized. It is a bidirectional relationship. And so now I want to move a little bit into how do we try to slide forward into the lives of the children in our communities to try to prevent the traumas that are leading to substance use disorder, or to try to prevent substance use disorder in these generations that are coming behind us. And so who has heard of the Kaiser Adverse Childhood Experiences Study, the ACEs study? Pop me a yes or a no in the chat box. Y'all look like y'all paying attention. I appreciate you. Yes, yes, yes. Okay. Vanessa said no, so I'll go through it. Perfect. So the Kaiser Adverse Childhood Experience Study was so interesting. They didn't know all of this data. Oh, please press mute. They didn't know that all of this data was going to come out of this study. So basically, Kaiser did a study of like thousands. I want to say it was like 60,000 members. The study population was overwhelmingly white, employed because they had Kaiser probably through their job. The average income bracket, I think, was like between 50 to 60. And what they did was ask these 11 questions. 10 questions. Did you experience any of these as a child? And for every single one of these that the person experienced as a child, they got 1 point. And what has since been shown since that initial study, in every single medical specialty, an ACEs score of 4 or more is associated with an increased risk of developing chronic medical condition later in life as an adult. And so what I put on this right-hand side for you, because we're talking about substance use disorder today, I pulled the slides that are substance use disorder. So for an adult who in childhood had 4, okay, look at this IV drug use chart, 0 any of these experiences as a child, then less than 0.5% of those adults have injected drugs. 1, it goes up about 1%. Your ACEs score is 2, 1.5%. Your ACEs score is 3, 2.5%. Your ACEs score is 4 or more, almost 4% of those people. So this is literally exponentially the higher your ACEs score. And remember, this is what happened in childhood, predicting health in adulthood. Same curve you see for smoking. Same curve you see for alcoholism as an adult. Same curve you see for premature birth. Same curve you see for high cholesterol. Same curve you see for chronic obstructive lung disease. Same curve you see for asthma. Same curve you see for diabetes. Childhood matters. Yeah, foster care experience, unfortunately. So that parental separation is an automatic ACEs score of 1 for any child that goes in foster care. Typically, a child goes in foster care because of other of these scores, right? And so when we look generationally at our kids, we should be educating our communities. We should be educating our families. We should be educating our parents. I took ACEs score when my husband and I had our kids. I was like, you probably have never heard of an ACEs score. So here's what it is, and here's what they are. And we need to keep our kids' ACEs score as close to 0 as humanly possible. And my husband and I set a goal together to keep our kids' scores low. When you are dealing with communities and families and children and adults, and you teach them this and they already have an ACEs score, then it becomes, if you already have an ACEs score 4 or more, I know you need an increased level of support. We need to wrap our arms around you even more tightly to try to keep that score from going up. But for the adults to address the impact that childhood ACEs score is having on them as an adult. The graphs don't lie. The impact is predictable and recurrent and reliable. And so that can help us be proactive, 1, about preventing ACE scores, but 2, about addressing them when we see them. And so if we're thinking in this framework of trauma, we really want to take a 3-step approach to this. And where we often make our big mistakes is that the first approach we make to a person or other social inequities, you cannot jump straight to action. So this is particularly for our faith-based communities as it relates to approaching people who have experienced the trauma itself of substance use disorder and all the things that came before it and that come after it. Number one is creating a safe space. The relationship between this and metabolic syndrome is what I said earlier, which is your stress axis hormone. So the higher the ACEs score, the more tonically high your stress axis hormone is. And cortisol drives high blood sugar, drives high cholesterol, drives weight gain, drives all of those hibernating survival behaviors, drives substance use. And so that's what the direct connection is. And so when we first make this approach to an individual, a family, a child, an adult, a community, first we have to be creating a safe space. So proactively create a safe space where people can just come and be. Go to the people and create a safe space where you can just come and be. The first approach cannot be, I see you need help with that drug use. It has to just be, I see you as a human. This is a safe space. Can I give you some food? Can we laugh? Can we play some music? Can we dance? Can we just be together in a nurturing, safe environment? And once it is safe, once the relationship is safe, it is still not time for action. You're still at grounding and physiological regulation. So that stress axis, that cortisol, is your fight or flight. So think about when something has just shocked you or traumatized you, the time it takes for your heart rate to come down, the time it takes for your muscles to relax, the time it takes for you not to be anticipating another scary thing to happen. That time, that grounding and that physiological calm down can only happen over time in a safe space. Because if you're continuously being traumatized, that's continually ratcheting up that fear response. And so you create the safe space just to be together as humans. You do that time to let those emotions come down, and then it's time for interventions and action. And so often we skip over phases 1 and phases 2 because we see that woman and she's pregnant and she's using drugs and we're worried about that baby and we need her to stop right now. And we go to her and we say, we need you to stop using drugs. I see you're pregnant. What do I need to do to create a safe space for you? What would bring you some joy right now? What would turn down the fear that you're having? How can I help? And work through those first 2 stages and then get to the third stage where you empower the survivor. So the survivor's voice has to be the loudest voice, period. And we don't think that people who use drugs can make decisions for themselves, and we steal that autonomy. And we act very authoritarian and patriarchal, and that is not safe. And that makes people run from us. That voice, their voice has to be the loudest voice. We are the ally. We are there to help them move forward. We don't have our own agenda. We're on their agenda. And so if we can enact this 2, number 1 is all about safety and time and space, 1 and 2. Number 3 is all about empowering the autonomy for that person to define what they are, what their life is going to be, who they're going to be, what their identity is, and us as allies operating to bolster that. We would be more effective. We would have better outcomes. We would have fewer people developing addictions. We would have more people recovering from addictions. And here it is. Matt Bell is in recovery himself from addiction. And he said, addiction to me is the epitome of disconnection. So in theory, recovery entails being connected again. And so what I would ask all of us, and this is our value set at Eleanor Health, relationship first and always, period. Relationship, connection, connection, meaning, connection, relationship, connection, meaning, connection, relationship, and connection. Period, period, period. And so in our last few minutes, I'll roll through this quickly, just some targeted interventions. Biopsychosocial model is a treatment approach that we use in all areas of medicine. It says that all illnesses, which addiction is a chronic medical illness, all illnesses have biological, psychological, and social reasons that that illness develops. And all illnesses have biological, psychological, and social reasons that they get better or they get worse. We've talked a lot through the psychosocial reasons about why addiction develops and why addiction gets worse. So I want to talk a little bit through the biological. I also don't want us to forget cultural, political. Stigma impairs health. Racism impairs health. Just make all health conditions worse, especially substance use disorders. And so this is just proving to you that mental health and substance use disorders are chronic medical conditions. One of the most stigmatizing, most frequent questions that I get is, but does treatment for addiction even work? We don't ask that question for asthma, diabetes, and hypertension because we just assume and believe that it works. When in reality, it works just as well for addiction as it does for any of the rest of these chronic medical conditions. So if we look at people who were in treatment for addiction, 1 year later, 40 to 60% of those are following the treatment recommendations. What we believe is that people with addiction don't listen. But guess who doesn't listen? Humans. Okay, because you look at asthma, you look at diabetes, you look at hypertension. As a matter of fact, people with asthma are listening less than people with addiction. People with diabetes, a little bit better on the medications, not on the lifestyle. The lifestyle is harder. People with hypertension, worse. And yet we don't tell people what's the point of treatment for hypertension, diabetes, or asthma, because we already believe in it. So we need to start believing in the treatment of addiction the same way we believe in the treatment for these others. Also, it doesn't work because they're just going to relapse as part of the illness. Relapse is a part of every chronic medical illness. So the definition of relapse is that you had a period of time where the symptoms were gone and now the symptoms are back. That's the medical definition of relapse. So for asthma, you had a period of time where your asthma attacks were controlled. Now your asthma attacks are out of control. That's a relapse. High blood pressure, you had a period of time your blood pressure was normal. Now your blood pressure is high again. That's a relapse. Diabetes, you had a period of time where your blood sugar was in range. Now your blood sugar is out of range. That's a relapse. And yet we don't judge those people for having relapses of their illnesses the way we judge people with substance use disorders. But check it out. Type it in the box for me. Does addiction's relapse rate at 1 year look any better or any worse than asthma, diabetes, or hypertension? It looks the same. It looks the same. And so that's our implicit bias. They're just going to use again and treatment doesn't work. That's our implicit bias and it keeps us from being helpful. And that stigma keeps people from coming in. Exactly. It's the same. It's the same. Dolores said, no, it ain't different. Right? And so you've seen this picture before when I was talking about implicit bias because it is the same neurobiological pathways that underlie addiction. And so when we look at that dopamine system over there, the black box on the right, it's a 3 neuron pathway. Deep brain, that. And what dopamine tells us is you need that to survive. And the reason it's important that the limbic system and the dopamine system are right on top of each other is because when we're in danger, the limbic system says you're in danger. But what also feels like danger is anxiety, depression, homelessness, being sexually assaulted, racism, being poor. All of that is danger. And so what your limbic system then does is makes your dopamine system send a signal to the prefrontal cortex that says, I know what resolves this danger. And when we look at the natural determinants of dopamine that feed forward to the prefrontal cortex and say, this resolves danger, it's food, water, sex, nurturing, because that keeps us alive. VTA is your ventral tegmental area. I'll type it in there for you because Deborah is nerdy like me. That's your VTA, right? And so what it does, your VTA goes, ping, we need that to survive. sends it forward to your nucleus accumbens that says, ping, we need that to survive. Sends that forward to your prefrontal cortex and says, prefrontal cortex, make a plan to make sure we never go without that, or we're going to die. We're not going to survive. And so the natural dopamine signals are food, water, sex, and nurturing. But the supernatural dopamine signal, food, water, sex, nurturing, that's the brightness of the light bulb. Cocaine, heroin, pain pills, marijuana, methamphetamine, cigarettes, 10,000 to 100,000 times bigger signal than dopamine. So if you ever knew anybody who chose drugs over food, or chose drugs over sex, or chose drugs over their family, which is nurturing, it's not really a choice when the dopamine signal is 100,000 times, when that survival message is 100,000 times stronger. And so what we do when we take care of people with addiction, what rehab is, the same way I just did training for us on implicit bias to catch that signal when it landed on the prefrontal cortex and to challenge it. What we train people in rehab is to catch that signal from the dopamine system when it lands on the prefrontal cortex and says, I know how to resolve this danger. You need this drug to survive. That they can grab that and challenge it and act in a different way than that initial reaction. And so if we start to understand the biology, this is the brain looking at it a different way. So this is what we call functional MRI. And basically, this is a study out of England where they put people who were 20 years in remission from cocaine use disorder, 20 years. And they put them in an MRI scanner and they showed them on the left a nature video. So like whatever, rabbits, deer, something beautiful but boring, right? And then and this is what the brain looked like. And then remember I told you amygdala is where fear and anxiety sits in your brain, and that's what feeds it forward to your prefrontal cortex. They showed people a video of people doing lines of cocaine. These are folks 20 years in remission, and they had to stop the study early because of cravings. When they saw those people on video doing lines of cocaine, that amygdala went on fire, and it tapped that VTA, tapped that nucleus accumbens, sent a furious message to the prefrontal cortex. If you don't get some cocaine right now, we are not going to survive. And they had to end that study for safety. And so when we're looking at people who have addiction, and we know the things that drive a risk for relapse are those things that create emotional danger and physical danger and uncertainty and takes away connections, that is COVID all day, every day. That is racism, that is marginalization, that is oppression, that is genderism, that is sexism, that is religious discrimination, that is all of those things that threaten our identity and cause us emotional and psychological danger, driving risk of relapse to substance use disorder. So I know we're at time, so this is the last thing I'm going to say, then we're going to race to the end. This is not just affecting this person. Epigenetics tells us that our experiences change our DNA. And that changed DNA is passed on to our offspring. So when we have a generation with high ACEs score, we have set up the next generation for higher risk for substance use disorders and other chronic medical illnesses. And so we have to do better.
Oh my God.
This is our goal, to intervene in all 4 areas: biologically, psychologically, socially, cultural, politically, for the individuals, the families, the communities, and the generations that we can affect. And with that, I will call it closed.